Hello everyone. Today we will discuss a radiograph approach to mediastinal lesions. We will see only chest radiograph approach to mediastinal lesions. We will not cover CT, and we will emphasize more on the frontal chest radiograph and what are the signs and which are the common lines which will help us to detect or to say whether the lesion is in anterior or middle or the posterior mediastinum based on the frontal chest radiograph only. Why it is important? Because it is the most common long case asked in a final radiology exam. And the second, in day-to-day practice, we have to pick up the mediastinal lesion to detect and to diagnose it in a fast way and in a quick way, and to send the patient to the CT. Okay, we will see one by one. We will see anatomy. Then, based on the anatomy, there will be pathologies, obviously, and then we will see how to approach on the frontal chest radiograph. This slide is showing the anterior, middle, and the posterior mediastinal divisions, how they are divided. Here you can see anterior mediastinum is anterior to the trachea, anterior to the arch of aorta, ascending aorta, and pericardium. Here middle mediastinum, in that there is trachea, carina, arch of aorta, heart with its pericardium. Whatever posterior to the middle mediastinum is in the middle posterior mediastinum. And in posterior mediastinum there is esophagus, descending thoracic aorta, spine with its neural foramina and neural nerve fibers coming out of the neural foramina. Then, based on the anatomy, we will see what are the pathologies. First, we will see posterior mediastinal pathologies. What are the structures in the posterior mediastinum? Esophagus, descending thoracic aorta, spine, neural foramina with its nerve fibers. So the lesions will be obviously esophageal lesions, hiatus hernia, foregut duplication cyst, then descending thoracic aortic aneurysm, neurogenic tumor, meningocele, paraspinal abscesses, then primary and secondary spinal lesions, and extramedullary hematopoiesis and Bogdalic hernia. Then coming to the anterior mediastinum, you remember 4 T's. First T is for enlarged thyroid extending into the anterior mediastinum. Second, thymoma. Third, to remember, terrible lymphoma. And four, teratoma. In the middle mediastinum, there are lymph node enlargement, then the tracheal lesions, then the arch of aorta aneurysm, and foregut duplication cyst, and pericardial cysts. Just to say on the foregut duplication cyst, there are two types of cyst. One is bronchogenic cyst, other is esophageal duplication cyst. Esophageal duplication cyst will be more elongated, more thick-walled, and more close to the esophagus. And the bronchogenic cyst will be spherical, thin-walled, and more close to the trachea. So what are the signs and what are the lines which are important on frontal chest radiograph? We will see. We will see Silhouette sign, hilum overlay sign, and then what are the lines in the anterior mediastinum? This is the anterior junctional line. What are the lines in the middle mediastinum? This is the right paratracheal strip, aortopulmonary window, and heart border. And what are the lines in the posterior mediastinum? We will see. And another important sign, cervicothoracic sign. This slide we will discuss about two signs, Silhouette sign and hilum overlay sign. What is Silhouette sign? If the two structures are in anatomical continuity with each other, then the line between them will be obscured, will not be sharp. So if we consider this is a hilum on the CT image, you can see the lateral border of the hila here, and it is seen very sharp because of the air here. So here you can see this is a sharp border of the hila. Why you can see? Because this lesion is not in a anatomical continuity here. So that's why you can see the margin between the two better. In other way, you can see silhouette sign is present, or it is not silhouetting the right hilar border. Then we will see hilum overlay sign. It is actually an extension of silhouette sign. You can see this mediastinal lesion, and you can see the sharp line of the hila here. So it will say either it is anterior or posterior to the hila. So this lesion is not lateral, not in anatomical continuity with the this border of the hila, but it has to be either anterior or posterior. So it is a hilum overlay sign. Then we will see anterior junctional line, and in the same slide we will see the posterior junctional line. First we will see the anterior junctional line. On CT, this is the anterior junctional line. It is formed by the opposition of the two lungs, and mainly because of the opposition of the pleura of the each lung. So four layers of the pleura, they are opposing to each other in the midline. So that's why this line is created. And remember, anterior junctional line will be inferior. You can remember AI, artificial intelligence, for that to remember. Anterior junctional line, it will be inferior to the posterior junctional line. And this anterior junctional line will end when the heart will start coming in the picture, when we go from the cranial to the caudal on the CT. Why? Because this pleural, the both lungs are getting separated now. So here you can see both lungs are opposing each other, but here you can see they are separated by the heart. So anterior junction line will start, but it will end above the heart. Then posterior junction line will be superior above the clavicle in the midline, but it will end when the aorta will start coming in the picture on the CT. So here you can see the aorta is here, but the two lungs are not joining each other posterior. So that's why posterior junctional line is seen up to the aorta only. So to remember, posterior junction line is above the clavicle, but it will end at the aorta, and anterior junction line will be inferior to the posterior junction line. Remember AI, anterior junction line inferior, and it will end when the heart will come. Now, so the same thing, this is the posterior junction line and this is the anterior junction line. Then the lines which are particular to the middle mediastinum, these are right paratracheal strip and azygous vein shadow. This is a CT image showing the trachea, and this is the right lateral wall of the trachea. Why it is better seen? Because there is lung lateral to it. And why the azygous vein is seen? Because there is lung lateral to it. So this is a frontal chest radiograph showing the same. This is the right paratracheal strip here. It is well seen here. And this is the azygous vein shadow. It should not be thick, and 4 mm for the right paratracheal strip and 10 mm for the azygous vein. Then aortopulmonary window. You can see the concave margin here between the aorta and the pulmonary conus. Here you can see the convex margin. So there has to be some pathology. So it should not be convex. It has to be concave. Aortopulmonary window. Then posterior lines. We will see the CT image. This is the vertebra. This is the right lateral border, left lateral border of the vertebra. Then these are the pleural reflections, and on the left side you can see the pleural reflection is far away from the lateral border of this vertebra. So on the left side we can see this paraspinal line better, and lateral to that the lateral border of the aorta, descending thoracic aorta. We will see the same on the frontal chest radiograph. This is the right lateral border of the vertebra. This is the left lateral border of the vertebra. Lateral to that there is a paraspinal line, and lateral to that there is a descending thoracic aortic border. Then this is the CT image. This is the esophagus, this is the azygous vein, and This is the esophagus, azygous vein, and its border, right lateral border, is well seen because of the air in the lung here. So on the frontal chest radiograph, you can see this is the azygoesophageal line formed by the esophagus anteriorly and azygous vein posteriorly. So these are all are posterior mediastinal lines. Then another important sign is cervicothoracic sign. Here on frontal chest radiograph, you can see the mediastinal lesion, and it is going above the clavicle. And if you see the lateral border of the lesion above the clavicle, and if it is sharp, then it has to be in the posterior mediastinum. And we can confirm it on the lateral radiograph and obviously on the CT. Then what is the logic? Because above the clavicle there is air lateral to the lesion, and if the lesion is in the anterior mediastinum, there is no air above the clavicle in the anterior mediastinum. So that's why only in the posterior mediastinal lesions we can see the sharp lateral margin of these lesions because of the air above the clavicle coming in the posterior mediastinum. Then what are the clues on the frontal chest radiograph? Lesion will be in the anterior mediastinum when there will be hilum overlay sign present and when the posterior lines are not obscured. When the lesion will be in the posterior mediastinum, when there will be positive cervicothoracic sign, or when there will be disruption of the posterior lines. And when the lesion will be in the middle mediastinum, when there will be right paratracheal strip widening and aortopulmonary window convexity, and when the lesion will cause obscuration of the border with the heart. We saw this. We saw why it is anterior, because hilum overlay sign is present. So lesion has to be either anterior or posterior. And why it is mostly anterior, because the posterior line, this is the descending thoracic aorta border, which is well seen. So it is preserved. So mostly the lesion is in the anterior mediastinum. We can confirm it by the lateral chest radiograph, and obviously CT we have to do in the mediastinal lesions. Then to remember 4 T's in the anterior mediastinum: thyroid, teratoma, thymoma, terrible lymphoma. We will see this in the image. This is the thyroid lesion on two important findings. One, it will be hyperdense on the plain CT because of the iodine content. Second, obviously it will be continuation of the enlarged neck lesion or the enlarged thyroid and going down into the anterior mediastinum. Teratoma, fat, calcium will be there. Lymphoma, thymoma, they will have non-specific features. In invasive thymoma, there will be peritoneal deposits with local effusion, and we have to do biopsy in these two cases to prove what it is. CT guided biopsy or UH guided biopsy you can do. This frontal chest radiograph showing cardiophrenic opacity. You can see this opacity is not that opaque as compared to the soft tissue, but it is more looking like this fat density. So it is nothing but epicardial fat. Then we will see when the lesion will be in the posterior mediastinum. There will be disruption of the posterior lines. What are the posterior lines? Azygoesophageal line, paraspinal lines, descending aorta line, cervicothoracic sign will be positive. Okay, we saw this. Okay, we saw this case. Okay, this was a proved schwannoma. Neurogenic tumor are very common, or are the lesions which are in the posterior mediastinum. In frontal chest radiograph showing what? Widening of the paraspinal lines. You can see the descending thoracic aorta sign. It is not obscured because the lesion is posterior to the descending thoracic aorta. Why? Posterior because the paraspinal lines are widened. Why it is not infective? Because intervertebral disc or the end plates are not eroded. Then what it is? This is the plain CT. It is showing typical lobulated outline of the soft tissue density, paraspinal, and obviously clinical history and bony changes. High attenuation on the CT. If it was splenomegaly, will lead to the extramedullary hematopoiesis diagnosis. Then this is opacity. It is not obscuring the hard border. On the lateral, you can see this opacity here. Then on CT, you can demonstrate defect in the diaphragm and the fat herniating into the chest. So it is a Vogtalic hernia. Morgagni hernia will be anterior. Frontal chest radiograph showing mediastinal winding, and we can't see the descending thoracic aorta side or border, descending thoracic aorta border. So on coronal CT, what we can see, what we are seeing an enlarged descending thoracic aorta with also a hypodense filling defect. It is a thrombus. Descending thoracic aortic aneurysm. This is the pediatric patient frontal chest radiograph. It is showing mediastinal lesion. On lateral, we can see it is lateral radiograph. We can see it is in the posterior mediastinum. So pediatric patient posterior mediastinal lesion. We should think of neurogenic tumor, and in that more important is neuroblastoma. This is a CT showing the lesion posterior mediastinum. So hope you understood. Okay, so this is a frontal chest radiograph showing the air fluid level in the mediastinum. So it is a very classic of hernia. Then what are the lesions in the middle mediastinum? We saw this location clues. Okay, we saw also this. Okay, this is azygous vein enlargement, azygous vein opacity enlargement. Sorry, and on CT there is lymph node here. What are the common causes of lymphadenopathy? Metastasis, lymphoma, sarcoid, tuberculosis. What are the important clues, especially on the CT? Calcification, enhancement, size, necrosis, location. Few important points. In untreated lymphoma, there won't be calcification. Axial calcification will be there in the sarcoid silicosis. In TB, we know there will be central necrosis, so there will be re-enhancement. Sarcoidosis, we know bilateral typical symmetrical hilar enlargement of lymph nodes, then mediastinal group will be involved. And usually in the lymphoma, mediastinal will be first, then hilar. Aortopulmonary window, convex here. On CT, there is lymph node. Aortopulmonary window, convex here, but on CT it is showing aneurysm. This is a frontal chest radiograph showing the opacity here. On lateral, it is in the middle mediastinum, very round. In the subcarinal region, in the middle mediastinum, what it can be. On CT, you can see a cystic lesion, subcarinal, close to the carina, trachea. It has to be bronchogenic cyst. Okay. Thank you very much for patient listening. I hope it was useful. Thank you very much.